We're just going to wait for a minute for all the other delegates to join, please. Thank you.
Yeah, I'll wait for another couple of minutes, and then I'll start. Okay, we'll make a start, I think. So welcome, everybody. Thank you ever so much for joining us tonight for this BPS webinar. My name is Graham Dunthorne. I'm a GP with special interest in pain management, and I chair the primary and community care specialist interest group for the BPS. So this is the first webinar organised by the SIG for quite some time. So thanks very much for joining us. It's great to have you all with us today. I'm just going to speak a little bit about the BPS and a few things that are coming up, and then I will do a little bit of housekeeping and then introduce our speaker for tonight. So the British Pain Society is the oldest and the largest multidisciplinary professional organisation in the field of pain within the UK. We aim to promote education, training, research and development in all fields of pain. The membership currently stands at over 800 and is, or at least trying its very utmost to be relevant to all manners of different people and all matters relating to pain. And we're endeavouring to increase both the professional and public awareness of the prevalence of pain and the facilities that are available for pain management. So in the primary and community care SIG, we particularly orientate ourselves towards those people who are working with pain and managing pain within the community. We're aiming to make education freely available, or at least at low cost, for all of those people, and to really kind of develop a community where we can learn from each other and we can support one another. We also want to ensure that training, qualifications, etc., are as available to people who enter pain management through community routes, which is becoming ever more prevalent, and to again increase public awareness about chronic pain and ensure that there is the maximum possible amount of things available for people who are living with chronic pain. So we are really hoping that these webinars are going to be a regular occurrence and we have planned one for most months for the rest of 2024, and they'll all be free for everybody to access. So please do keep looking at the BPS Twitter feed and the events page for those. In May, after some feedback, we're just going to organize a general sort of chat and meet, talk about your experiences working within pain management in the community, any challenges that you might have. And that event is going to be open to absolutely anybody. You do not have to have BPS membership to come to that event. Okay, I'll just talk a little bit about the ASM then, Esther. Yeah, so this is the annual scientific meeting for the BPS, happening in Nottingham this year between the 4th and 6th of June. So please do take a look at that as well. On the day before that, so that will be Monday, the 3rd of June, the primary and community care SIG are collaborating with the pain management program SIG to do a day which is going to be specifically orientated around pain management programs. And we've got some great speakers coming to do talks and workshops at that event. So the Nottingham team are going to be doing a workshop around young people's pain management programs. We are doing a talk and workshop around sleep and pain and principles of CBTI. And we also have Lance McCracken, well-known pain psychologist, coming to do a talk around kind of modern day pain management programs and pain psychology and how sort of face-to-face stuff fits in the digital age. So it'd be great to have you here for that as well. We do have to obviously charge for that, a full day of CPD, and it is going to be £99, but you will get lunch and coffee with that and hopefully some fantastic CPD. So please do take a look at that too. Right, so I think that's the kind of advertising over with, and we just moved to this evening's webinar, a little bit of housekeeping. So it's a live event, so you can't sort of put on your camera and speak to us, but you can put your questions in the chat, and we will endeavour to answer as many of those as possible at the end. So please do add those as you go along, and I'll be keeping an eye on that. The session is being recorded, and next week you will receive an email that will have your certificate of attendance. It will have the recording, and it will also have an evaluation. We are really working hard to try and increase the amount of webinars available. So your feedback on how this evening goes would be very much valued. Okay, so tonight, as I said, is our first webinar, and we're going to be covering the subject of neuropathic pain. And when I started chairing the SIG, I wanted to improve the collaboration and understanding that we have between primary and secondary care. We put a call out to the consultant body within the BPS, hoping for some contributions towards that. And tonight we are delighted to welcome Dr. Thanthullu Vasu, who very kindly answered that call. Dr. Vasu is a consultant in pain medicine with over 30 years experience. He's currently working with University Hospitals of Leicester, and he's previously been elected council member of the BPS and honorary editor of the BPS's newsletter, Pain News. He is extensively published, and he's the author of multiple books, including the first international evidence-based textbook on long COVID syndrome. He has lectured in many patient and public forums and received the Grenfell National Pain Award in 2016 for his relaxation and distraction workshop for children in chronic pain and their parents. He's working with over 70 volunteers to widen the access to medicine for young students in the Leicester area. And he's received the Leicester Asian Doctors Society Award in 2024 for empowering the younger generation. Takes part in several charitable events, and he's founded a local talk program and walking group in Leicester. So I really do hope that that does you some justice, Dr. Vasu, and I will pass over to you to talk to us about neuropathic pain. Thank you ever so much.
Thanks, Graham. Thanks for the kind words. First of all, let me thank British Pain Society for inviting me to give this talk on neuropathic pain. Thanks to Esther, who is sitting behind and organizing the whole meeting this evening. Dear audience, thank you all of you for coming on the weekday on a Thursday evening after a busy day at work to listen to this lecture. I hope I can make it a bit useful for the whole lecture. I will try to talk for 20. I would try to look at having some discussions with you. So if you can put your questions on the chat, Graham will collate it, and then we will have a chat at the end. It will be more useful to have discussion rather than me lecturing alone. Considering it's a busy day and in the evening, I'll try to keep it as simple as possible. Some of this might be very basic to you. Let me start with a humorous story. I'm sure some of you might have heard this story, but chronic pain is very complex. So one of the young doctor was working hard, and then an angel thinks that I will come and give some boon to this doctor. So the angel comes and asks, what do you want? So the doctor wants to go to America. So says, I want a high-speed motorway just going across the Atlantic Ocean to America, and I should reach within a couple of hours. Then the angel says, see, you need to ask something practical. This is not going to be possible to have a motorway across the Atlantic Ocean. So ask something much practicable. Then the doctor says, I want to cure all the chronic pain patients that I see in my clinic. And then the angel thinks for a minute and says, you ask for a motorway. Do you want a double lane or a 3-lane road? So chronic pain is very frustrating. That's the story I wanted to tell. And most of you would see the majority of the chronic pain in the primary care and community. At hospital, we see the bulk. We don't see the bulk. We see the tip of the iceberg. So there is a huge incidence of chronic pain. The Pain Society, as well as various guidelines, say that the incidence of chronic pain is around 10%. That's the average estimates. So 1 in 10 who are surrounding you will suffer with chronic pain, and they need care. Considering the way the waiting lists are growing, considering the way the services are available for chronic condition patients, this is going to be a challenge for clinicians like us. Next slide, Esther. So in this slide, in this talk, Graham asked me to talk about neuropathic pain, and I'm going to keep it to very, very basics. Next slide, please. Yeah. Neuropathic pain is very challenging. And International Association for Study of Pain, the IASP, a decade ago, 2014, announced that it was a global year against neuropathic pain. So that was the importance given to neuropathic pain. Down the line, 10 years later, I think we are still faced with the same challenges to deal with neuropathic pain. Next slide, Esther, please. So I don't need to lecture you on chronic pain. Most of you know what chronic pain is. Acute pain is what happens immediately after an injury or a trauma or a stimulus, and it serves a protective function. And usually there is a noxious insult behind this. But when this pain persists for more than 3 months or so, then it becomes chronic. And we all know that chronic pain serves no function, but no protective function, but it always affects the health and the quality of life of the patients who suffer with chronic pain. Next slide, please. So what is neuropathic pain? We used to term neuropathic pain nociceptive pain, but recently we also have something called as a neuroplastic pain. So neuropathic pain is a pain caused by lesion or a disease of the somatosensory nervous system. So it can be attributed to damage to the sensory nervous system or alternating signals given by the system. So is there a typical localized diagnosis for neuropathic pain? I'll come to that later, but the nociceptive pain and neuropathic pain mostly coexist. So this was one of the graphs produced by one of the European studies quite a decade ago. So if you look on the left-hand side, there is the inflammatory pain mechanism. And the authors looked at whether they have inflammatory pain mechanism or neuropathic pain. So on the left-hand side, you look at osteoarthritis and rheumatoid arthritis. And most of these patients have inflammatory pain, but even they have some amount of neuropathic pain. So you would have seen like a rheumatoid arthritis patient coming and describing a burning pain, for example. The same thing, you would have seen pure neuropathic pain, what we think as pure in post-herpetic or phantom limb pain. And these patients also sometimes tell that anti-nociceptive medications do work. So it's a combination, but you can only say a proportion. So like conditions like osteoarthritis, rheumatoid arthritis have more inflammatory cause, whereas post-herpetic neuralgia, phantom limb, or diabetic neuropathy have more sort of neuropathic features. Next slide, Esther, please. So coming to the case histories, what you would see in primary care, I can discuss a few cases which happened in the last week. These are not the photos of those patients, but I've taken from the internet. So 67-year-old lady who came with post-herpetic neuralgia, significant pain in such a way that in that thoracic dermatome, she was not even able to wear the clothes, and even clothes, light touch was causing severe pain. This is what we call as allodynia, which means touch causing pain. It is a significant pain, and these patients clearly tell you that the pain is so severe that it makes them suicidal, and it is it affects the quality of life significantly. So you might see these sort of burning pain localized to a dermatome in your practice. Post-surgical pain or chronic post-surgical pain is a very common feature. There is a study from Pennsylvania, the deanery down south, which has said that 1 in 3 patients after knee replacement come with pain, although radiologically they are perfectly fine. Surgeries like thoracic surgery, breast surgery are very common to have post-surgical pain. So in your primary care practice, you might be seeing a patient who has had a surgery, and the surgeons have discharged saying that everything is fine, but the patient complains of pain more worse along the scar. And they describe a neuropathic pain of burning pain, pain on touch. That is very commonly you might see in your practice. Diabetic peripheral neuropathy. So patients with diabetes always have glove and stock loss of sensation in the feet. They can damage it, they can get ulcers, but more worse is the peripheral neuropathy. It can be disabling for the patients. They complain like as if they are walking on a cobblestone or on a thorn, and they describe of pain which affects the quality of life. They stop walking due to this, and they come to you asking for help. It is quite common in diabetic patients, especially if the blood sugars are not well controlled. Lumbar radicular pain. Back pain is very common, and I'm sure you would see back pain patients in your everyday practice. But some of the back pain patients have nerve compression, and they can complain of radiculopathy, that is a shooting pain going down the leg, and that can cause weakness and can cause long-term effects. Post-stroke pain is an example of central pain, where patients after stroke complain of pain on either one side of the body or both sides of the body. The common descriptors of neuropathic pain is like pattern recognition. When they come to your clinic, they say like the pain is shooting in nature, sometimes shock-like, electric shock-like and tingling in nature, burning sensation, and sometimes they describe a numb sensation whereas they feel the pain. These are typical descriptors of neuropathic pain from patients. Next slide, Esther, please. So as I said earlier, the IASP definition, the International Association for Study of Pain, defines neuropathic pain as a pain caused by a lesion or a disease of somatosensory nervous system. So it is a clinical description, and there is no diagnosis as such for neuropathic pain, though the research quotes a few descriptors which can be added together as a diagnosis, but it is a clinical diagnosis. The neuropathic pain either could be central or peripheral. Peripheral is what I said, like nerve damage and conditions which affect the peripheries. Central is where the pain affects in the second order neurons in the spinal cord, or it can affect the higher centers in the brain. So that's how it is differentiated. Common examples for peripheral pain is disc prolapse and nerve compression, diabetic peripheral neuropathy, post-herpetic neuropathy, pain due to radiation therapy, HIV infections, those sort of things. Central pain is pain after stroke, spinal injury, multiple sclerosis, metabolic causes, and neurological causes. So next slide, please. So I'm not going to bore you on a busy evening with this complex slide, but there are huge number of mechanisms to say why neuropathic pain happens. Whenever you have huge number of mechanisms, that clearly says that we don't know the definitive cause for why this happens. But all the research has shown that there is lots of electrical changes which happens in the nervous system when a patient has neuropathic pain. I'll go to the next slide, please. To summarize, the next slide shows that there are changes which can happen centrally in central neuropathic pain, peripherally in peripheral neuropathic pain. It is a very complex conception, but what I would say is in peripheral neuropathic pain, there is ectopic or abnormal discharges of electrical stimulation, changes in the channels like calcium channel and potassium channel and the sodium channels which conduct the electricity, And there is abnormal sprouting of neurons, and they can link with the sympathetic receptors, which can cause sympathetic related pain, and the receptors can get sensitized. Whereas centrally, we call something called a central sensitization. Any persistent pain changes the way the brain reacts to the stimulus. And this can happen either in the spine or in the cortex, as well as the descending inhibitory pathways in the pain can be altered in neuropathic pain. Next slide, Esther, please. So there has been a call to say, let us find out the mechanism and we treat according to the mechanism, because we know that each and every medication works in a different receptor, and each medication can be used in different types of pain. So the detailed mechanism, unfortunately, is not clear. The neuropathic pain is complex and it is occurring due to various mechanisms. It is better to find the etiology, not because the mechanism will lead to treatment, but the etiology means that we can treat the primary cause, but the mechanism will help to give the right medication, which I'll be discussing in the following slides. Next slide, please. So how do we diagnose neuropathic pain before we go to treatment? There are positive sensory signs or negative sensory signs. What are the positive signs? In chronic pain clinics, we always discuss positive signs like allodynia. Allodynia is normal touch causing painful sensation. That is called as allodynia. We can call something as hyperalgesia, which means you are giving a painful stimulus, but there is an exaggerated response to the pain stimulus. That's called as hyperalgesia. So allodynia, hyperalgesia, dysesthesia, which means abnormal sensation. These are positive signs that the patient tells that they have these signs. What are the negative signs? Hypoesthesia, abnormal reduction in sensation, and abnormal feeling that they don't feel the sensation. That's all that comes under the negative signs. Obviously, there are various nerve conduction studies and neurophysiological studies which can be used. Both clinical and diagnostic features can define neuropathic pain, but in our routine clinical practice, we give a diagnosis of neuropathic pain based on clinical signs rather than a diagnosis or tests. Next slide, please. So how to test? I'm not going to give a detailed lecture on this, but always we look for the sensations. A beta fibers, which we read in physiology, will be testing the touch stimulus. So we can test with a cotton wool or brush. Vibration can also be tested for the A beta. So if there is an injury in the A beta, or if there is an abnormal mechanism in the A beta fibers, then touch and vibration can be affected. If A delta is affected, then sharp pinprick sensation and cold sensation can be affected. Warm sensation when tested will be affected if there is a C fiber damage. Obviously, there is autonomic function like sympathetic mediated pain, CRPS, complex regional pain syndrome. In those neuropathic pain, sympathetic fibers will be affected. In some neuropathic pain, motor fibers can also be affected. Next slide, please. So the 150th Chief Medical Officer report from the Chief Medical Officer of NHS England and Department of Health said that chronic pain is a big problem that we are going to face, and it is going to increase as time goes on. Next slide, please. Neuropathic pain is quite common, and you will I would estimate that roughly around 1 in 5 of the pain clinic patients present with neuropathic features, which presents as a major symptom. Always pain is managed in a biopsychosocial model, because what we evaluate is nociception, but what we should look for is the biopsychosocial model. So pain nociception, the physiological nociception, is a small part of the whole pain, but there are attitudes and beliefs surrounding this, which is another layer of this onion, which we have to peel before we treat. So patient can have abnormal belief of pain, which can lead to what we call as catastrophizing, which means there is an abnormal fear of pain, which restricts them to move. Added to that on the top is the suffering that the patient is having. We can help with the suffering, but not cure the pain. Pain escape behavior, the social support system, they all can be the layers which affect it. And pain has to be looked in a multimodal way in a biopsychosocial model. Next slide, please. So I would use this slide, and this is one of the interesting studies which has changed the concept of how pain is managed. This is produced by Blayan, one of the psychologists, nearly 2-3 decades ago. And what we normally see in patients is what is on the right-hand side of the slide that I have presented. So whenever a person has an injury, they have experience of pain. And most of us on the right-hand side have no fear and we confront the pain and bear the pain and carry on being active and recover from the condition. Whereas people who suffer with chronic pain are on the left-hand side of the slide. So they have pain after injury, but they go into, as I said earlier, catastrophizing, which means abnormal fear of pain that is due to the negative affectivity and threatening information that they might have received. That can lead to fear. Fear will lead to avoidance of movement and hypervigilance, which they think like they are protecting themselves and stop moving. That can lead to disuse, depression, disability, and this pain becomes vicious cycle going on and on. So the aim of a clinician would be to prevent this vicious cycle going on and lead the patient towards the right-hand side to confront the pain and recover. That is the principle for any chronic pain and more so in neuropathic pain. Next slide, please. So the main aim of the talk today is to look at management, pharmacological management of neuropathic pain. So evidence-based pharmacological management is the key to successful outcome. So I'm going to talk about what is the evidence available at the present time. But the goal should happen after you treat the cause. For example, if a patient comes with diabetes, education about control of blood sugar is very, very important, and treating the cause, because without curing the primary cause, you're not going to get benefit by just giving the neuropathic medications. Next thing is secondary prevention. For example, if a patient has a stroke, then giving antithrombotic measures. So secondary prevention is the key. So treat the cause and treat. For example, if a patient comes with vitamin deficiency, which causes neuropathic pain, then they need to be monitored and supplemented. So treating the cause, looking for secondary prevention comes before we start the medical management. Next slide, please. The goal of the pharmacology is to improve the quality of life. Most of the pain clinics don't cure the pain. And as people who outside the pain clinic think like, what is the point? The pain is not gone. But the aim is not to improve the pain, but the aim is to improve the quality of life. By quality of life, what we mean is that they engage with their identity, what they have. We'll try to improve their mood, improve the sleep, and try to reduce the medications that they are taking, or balance it and optimize it in a sensible way. Proper education, reassurance is the key to go towards long-term management. Without education, for example, if a patient comes with post-herpetic neuralgia, they get so frightened that it is a cancer or something sinister. So education that, yes, it is post-herpetic neuralgia, and we see this, it settles with time, provided you can desensitize the area. And the education is the key towards treating the patient. Next slide, please. So when do we need to refer to the specialist centers rather than treating itself? I would suggest start the treatment before you refer, because there are guidelines, local formularies available in your area, or you can use the nice guidelines, which I'm going to say. But think about referring to a multidisciplinary pain clinic when the pain is so severe that they are not able to have a good quality of life. Or if the patient has significant limitation in the lifestyle, daily activities, and participation in their role, or if the health condition has deteriorated. This is what the NICE guideline says. Most of the pain clinics will accept a referral if they see these sort of features, like the pain is so severe, you've tried simple things before referring to them as per the formulary, which I'll be discussing in the next slides, and still their quality of life is limited. And especially if it is neuropathic, then we tend to accept the referral and look at what other things we can do. So next slide, please. So I'm going to start with the NICE guidelines, because all the treatments in our NHS is based on NICE guidelines. So NICE guidelines, the clinical guideline 173 came nearly 10 years ago in 2013, and we still follow the guidelines because the evidence or the research has not changed much. So what does NICE guideline say with regards to neuropathic pain? It says that the initial treatment, of course, we need to reassure, educate before we go to the pharmacological treatment. That's what I covered in the previous slides. But with regards to pharmacological management, it says that we need to offer one of the 4 drugs: amitriptyline, a tricyclic antidepressant; duloxetine, a SNRI medication; gabapentin, which is alpha-2 delta ligand and comes under calcium channel blocker, gabapentin; or pregabalin, which also works on the alpha-2 delta ligand. So these are the 4 drugs which should be the first line of treatment: amitriptyline, duloxetine, gabapentin, or pregabalin. It doesn't say which one you have to use first. You can use any one, except there are exceptions I'll come to later, but you can use any one drug. My clinical practice usually is to start with amitriptyline because it is cheap drug and it is easily available and it is easily titrable. You can titrate it easily. But if there are cardiac problems, rhythm problems in the heart, then you might have to choose a different drug. My second line would be pregabalin in my clinical practice. It's just my suggestion, not the guideline. The guideline says you can use any one drug. Why pregabalin? Because it has better pharmacokinetics and better suitability bioavailability compared to gabapentin. Gabapentin is the next line, and I keep duloxetine as the last one because it has got some side effects, which I'll come to later on. So you can select any one of the drug. I'll tell in the next slide what dose and how to prescribe. And if the initial drug, what you started, is not effective or not tolerable to the patient, then you can offer one of the other 3 drugs. If the initial drug is effective, but not as effective as you want, then you can keep it as a small dose and you can add the second drug. That is my clinical practice. So for example, if amitriptyline helps at a small dose and you try to increase it, they have side effects, then you can keep the small dose of amitriptyline and add pregabalin or gabapentin. The reason is both these medications, amitriptyline, gabapentinoid, and duloxetine, all of them work on different mechanisms on different pathways. So synergistic action by using a small dose of combination of drugs has good scientific evidence. There is only one exception to this first line drug of treatment, which is trigeminal neuralgia. They suggest carbamazepine as a first line treatment. Still, in my clinical practice, though the NICE guideline says, I try to use gabapentin or pregabalin because it is more familiar to the primary care prescribers to follow up, as well as it's much easier, needs less monitoring compared to carbamazepine. But if you talk scientifically, looking at research, carbamazepine has better evidence in trigeminal neuralgia, and that is why NICE guideline recommends this. But it all depends upon which is easy to practice and what is easy to follow up, then it is your wish of how to do. But carbamazepine has better results based on evidence for trigeminal neuralgia alone. Next paragraph, next slide, please. NICE guidelines also suggest a couple of other things. Tramadol for acute rescue drug, and it should be used only for a short term. Why tramadol compared to other opioids? Why can't we use other opioids, you might ask? There are 2 reasons. One is tramadol has action on noradrenergic pathway as well as opioid pathway. But I personally feel that the tramadol is recommended because studies have been done on tramadol rather than morphine or cocodamol or codeine. The studies are available only for tramadol for neuropathic pain to give a certain amount of evidence to prescribe that. Localized pain, you can use capsaicin cream. That is what NICE guideline says. Unfortunately, capsaicin is not available easily nowadays because of restriction in manufacture, but specialist services and tertiary units in the hospitals can use 8% capsaicin, which is like Quitensa patch, which they apply, and it might be available in your area. Next slide, please. There is one change in 2019, which the NICE had to make an announcement. The reason is gabapentin and pregabalin were scheduled as class C substances, which means it became a controlled drug. I'm sure you all know that. It became a controlled drug because there were lots of white papers which were presented, as well as there were papers which came from prison services, where we realized that pregabalin and gabapentin were the most abused drugs. And even in the community, it became as a most abused clean drug sort of thing. So the government had to ask to make it as a controlled drug so that adequate monitoring is done for this. But the NICE guideline came back and looked at, because it's a controlled drug, should we change the recommendation? But they found that although it is a controlled drug and it has been abused, gabapentin and pregabalin was effective in most of the neuropathic pain. So they suggested that the guideline stays the same and we need to carry on using it. But we know that being a Schedule 3 controlled drug, we need stringent requirements to monitor it and prescribe it. Next slide, please. So recollecting how to prescribe amitriptyline. Amitriptyline, we usually start at 10 milligram per day. We usually give it in the night time, preferably in the early evening rather than late at night. Why? Because it can cause drowsiness in the morning. And we increase it up to 50 milligrams at night time. That's my practice. Although the NICE guideline says 75 milligram, I personally feel like, in my experience, like if you go more than 50, it doesn't give much benefit at all. But you can try as per the formulary if you want. But my practice is to seal it at 75, 50 milligram and then look at adding another medication if we need. Side effects, it has to be carefully given if a patient has a rhythm problem of the heart, arrhythmias, because it's a tricyclic medication. It can cause dry mouth. Tolerance happens to most of the side effects like drowsiness, concentration problem, but the dry mouth, there is no tolerance. So you need to advise the patient to drink lots of water. If the side effects are excessive, my practice is to change amitriptyline to nortriptyline, which seems to work in some of the patients. If they had benefit with pain relief, then if they have side effects, there is a chance you can alternate with nortriptyline and see whether it helps. Some people say it gives better sleep quality, nortriptyline, but there is not huge evidence, but you can try it. Coming to pregabalin, the NICE guideline says that we need to start at 75 milligrams twice daily, which is 150 milligram per day. My practice is to start slightly lower than that. In an elderly patient who comes with multiple other problems, I usually start at 25 milligrams at nighttime and increase it to twice daily. In fit patients, I start at 75 milligrams. So it's a range where I feel, but the NICE guideline says start at 75 milligrams twice daily, go up to 300 milligrams twice daily, 600 milligrams. So pregabalin has better pharmacokinetics. It has better bioavailability. So we need to give it as twice daily rather than 3 times a day. Next slide, please. Gabapentin, we start at usually 100 milligram or 300 milligram, and we give 3 times a day. And the maximum dose, the BNF says, is 3,600 milligram, but I usually stop at 1,800 milligram, which is 600 milligrams 3 times a day, because the availability, the bioavailability reaches a plateau at 1,800 milligrams, and you don't see much benefit after that. Duloxetine, we start at 60 milligram a day and go up to 120 milligram a day. I have seen some patients who have had hallucinations, suicidal ideas. So monitoring for these side effects are very important. That's why I use it as a 4th medication if other 3 don't work. Next slide, please. For diabetic neuropathy, as the previous slide said, the recommendation is duloxetine, but I still start with amitriptyline and gabapentin. So when you review the patient, you need to look whether the patient has had improvement. If the improvement is sustained, then we can consider reducing the dose to see whether that makes any change. If the side effects are not tolerated with amitriptyline, you can try nortriptyline or imipramine. As I said earlier, nortriptyline is a better choice. Next slide, please. I'm sorry for the complex slide. I'm not going to go through this slide, but there are European guidelines produced by FINERA and European Pain Federation, and it is more or less the same. It's nothing different, but it takes about local regional pain, look at giving lidocaine patch or capsaicin, and on the other side, it goes to systemic pain and changing the medications. So basically, the guidelines are more or less similar. That's the message from this slide. Sorry for the complex slide. Next one, please. Next slide. So this is the European Federation of Neurological Sciences evidence. What I said in the previous one, the first line is tricyclic gabapentin or pregabalin. It doesn't mention duloxetine, but except trigeminal neuralgia, go for carbamazepine. It adds lidocaine plasters, whereas NICE guideline doesn't mention that. In our hospital, we are allowed to prescribe lidocaine for post-herpetic neuralgia alone, not for other conditions. Duloxetine and other SNRIs for painful diabetic neuropathy. And second line, it also adds opioids. But I would be careful with opioid. Given the opioid-aware document, be careful. A small dose is fine, but if you're going to increase it, then you need to be having a care, and the bell should ring in your mind to keep an eye on that. Next slide, please. I'm not going to go into this slide, but this is based, why were they basing this evidence? That is based on the studies. But as you can see, the dots, the black dots, it vary from small dots to big dots. The big dots means that they have more studies to say, but the recommendations have come from smaller dots also. Next slide, please. So I've expanded that in this slide. If you look, like gabapentin and pregabalin are more recommended because we have used huge numbers. Other drugs have been used in smaller trials. And the number needed to treat is on the x-axis, whereas in the y-axis, we see number needed to harm. And we have to base both of them when look into recommendations. Next slide, please. So before prescribing, select the right patient. Make sure you manage the expectations of the patient. Because if they come for looking for a cure, medications are not going to be the cure, but it will help to set some goals and help manage. While we prescribe the medication, make sure they have the adequate information, and it is a safe practice when we look for polypharmacy and other medication reactions. After we prescribe, make sure you review so that you can modify the dose and monitor that it is still working. Next slide, please. This paper, I liked it very much. It is more than 10 years ago. Andrew Moore produced it from Oxford. The patient looked at chronic pain, but I would like to say about this in neuropathic pain also. The title of the paper was Expect Analgesic Failure, Pursue Analgesic Success. The gist of the paper is they looked at many systematic reviews and many RCTs and came to a conclusion that most of the drugs, the pain analgesic drugs, work only in a small percentage of people. So it is not going to work for 100% of the people. Most of the studies looked at either 30% pain relief or 50% pain relief, and it was looking at a wide variety of conditions. But still, we should start looking, we should keep looking for the analgesic success. Why? Because it works in a small percentage of people, but we need to find out which drug works. We need a huge amount of variety of drugs in our armamentarium, because neuropathic pain can happen due to various different mechanisms. And failure in one class of a drug doesn't mean that other subclass drug will not work. For example, if one of the tricyclic antidepressant like say amitriptyline fails, it doesn't mean nortriptyline might not work. So the authors say that failure in one group like gabapentin doesn't work, it doesn't mean pregabalin won't work. So one group SNRIs, any one drug, if it doesn't work, try the other drug. You need to keep searching because these medications can improve the quality of life. And the main point the study says is, if a trial of 2 to 4 weeks has not helped, that means it's not going to help. You need to stop the medication. So review of the patients after 3 or 4 weeks time is very important, so that we save the patient from having side effects of the medication, and we save the cost related to the medication also. And we also save the side effects and the related healthcare cost due to that. Next slide, please. British Pain Society has huge number of guidelines. I'm sorry for the complex slide, but if you go to the publications in the BPS website, there are leaflets for amitriptyline, duloxetine, gabapentin, pregabalin, all the medications. So when you see a patient, you can print them and give them this. This is a national leaflet, so it has more scientific evidence behind it. I would suggest you to go and have a look at a website of BPS. Next slide, please. So as I promised, I wanted to finish in half an hour. I might have gone a bit more, but I'll try to take as much questions as possible. If you can start typing the questions now. And conclusion, summarizing, neuropathic pain can significantly affect the quality of life of sufferers. So listen to the patient and do your best to help them. It can improve the quality of life significantly, even small changes. Empathetic approach, education and reassurance is the key. Without that, the treatment is going to fail. There is a choice of 4 drugs, amitriptyline, duloxetine, gabapentin, and pregabalin as an initial treatment based on NICE guidelines. I changed the order. In my clinical practice, it's amitriptyline, pregabalin, gabapentin, and then duloxetine. Always, whenever you start a treatment, review and reassess the condition. There is a significant chance that majority of them, it might not work, and you might have to look at changing the dose or changing the drug, or in a same class or in a different class. Most drugs work only in a small percentage of people. Finally, if the treatment has not worked and if the quality of life is still poor, consider referring to the pain clinic. Next slide, please. Thank you very much, all of you. I know it's a weekday, busy evening, and you've had a busy day all day. Thanks for coming for the meeting. And I wish the primary care SIG all success. And I hope there are more meetings in the future. And I thank once again BPS, especially Esther, who has worked all night today, and Graham for giving me the opportunity. Thank you very much. And you can stop sharing the slides and we can take questions now, Esther. Thank you.
Fantastic. Thank you ever so much, Dr. Vasu. That was a really informative presentation covering so much so concisely. Thank you. So yeah, please just, there is one question in the chat at the moment. So I shall, or a few more coming. So I shall read a few questions out. I've got a few more of my own as well, if we need them. And yeah, hopefully we can have a good chat now. So the first question, which I think you probably did answer shortly after the question came, but I'll just read it again. It says, for the first line treatments, when can I consider a failure treatment? So I think that probably means, apologies if I'm wrong, kind of how, let's say you're prescribing pregabalin. If the patient comes back and they're on, I don't know, 300 milligrams or 400 milligrams a day or something, are you going to keep going until you hit 600 to be absolutely sure, or are you going to stop at some point? What's your kind of advice there?
I think this is a quite interesting question. Yes. When do you consider it as a failure? That's the question, I know. And as you said, Graham, it is a bit difficult based on individual patient. A trial should happen for 2 to 4 weeks, and then we need to review the patient. And if the patient says the pain relief has not happened, then start questioning them, asking about other things. Have you been active? Have you slept well? Sometimes the patient might tell that pain has not gone and come back to you, but their quality of life might have improved significantly. So question that first. The second thing is, yes, try to increase the dose if you have started on a small dose, and if you can still go to a higher dose. As Graham said rightly, if you are on a 300 milligram, I would still go to 600 milligram of gabapentin 3 times a day. Whatever drug, if amitriptyline, I usually go up to 25 milligram and see the effect. You can go up to 75 milligram, but 25 milligram is my ceiling. I go up to 50 if it works. If not, I add another drug. Gabapentin, I go up to 1800 milligram, which is 600 milligrams 3 times a day. Pregabalin, I always tend to go up to 600 milligrams a day, which is 300 milligrams twice a day. Duloxetine, I try to hesitate to go more than 60. But if they have had side effects, I wouldn't increase it. It all depends on the patient. Some patients come and say, like, yes, it worked very well. Pain has eased significantly, but I'm feeling very sleepy and I'm not able to go out. Then that doesn't serve the purpose. Our goal is not to cure the pain or treat the pain. Our goal is to improve the quality of life, make sure the patient is keeping active and engages with their community. So that is the goal. And if after 4 weeks, if you have reached a maximum dose and if it has not helped, please wean it again and stop it. Don't stop it abruptly, wean it gradually again. Because sometimes the patient will say it didn't help at all. But when you start going from 600 milligram pregabalin to 300, they will say, like, oh, it was helping me. Suddenly it has gone very high. So that gives you an idea. So the problem with these sort of neuropathic medications is titration. You need to go slow and go gradually up. And the same way, when you stop it, come down slow and gradually down. And in that way, amitriptyline is easier to titrate compared to gabapentin or pregabalin. But if one drug has not worked and the patient has said, then I would add another drug or change to another drug, definitely. I hope that answers the question, Graham.
Yeah, no, fantastic and comprehensive. Right, this next question is a great question. It is very topical, so really interested to get your thoughts on this. So in one of your early slides, you had radicular pain as a cause of neuropathic pain. And of course, as I'm sure many people know, NICE updated their guidelines for low back pain and sciatica in 2020 and advised that we no longer prescribe gabapentinoids. And my understanding of this is that essentially there's no evidence body to support the use of those drugs in radicular pain. But many different views are, I think, floating around on that. So yes, yours, please, Dr. Vasu.
Okay, I think the NICE guidelines for back pain was based for back pain and sciatica. And NICE has recommended that we shouldn't be using gabapentin and pregabalin in axial back pain, basically. So if you have back pain, which is affecting the back, then yes, I totally agree that we shouldn't be giving the neuropathic medications for those conditions, because that's going to cause problem. They don't have any radicular pain, though they might complain about leg pain. If the pain is mainly in the back, then there is no point in continuing with the radicular management. Whereas with the sciatica or whether the radicular pain, I still find that pharmacologically we can carry on with the gabapentin. So what the NICE guideline says, the 2020, is if you go back and have a look, there is 1.2.18. That is the recommendation, what it makes. It clearly says that you can give gabapentin for sciatica if there is radicular pain, but you need to explain the risk to the patient. That is what it says. So it says the patient is already taking opioid, gabapentinoid, or other medications, carry on taking it. My clinical practice is if there is a radicular pain, which means that the leg pain is worse than the back pain, and it is unilateral, one leg is affected, they have weakness of the leg, gabapentin or pregabalin has a role, and you can give it. And I'm sure the NICE guideline will allow that. But it does say in the beginning, like the evidence of benefit is less than the evidence of harm. That is why initially it said that do not offer gabapentin. But on the other hand, there was a contrary thing saying, like, if the patient is already taking gabapentin, explain the risk. So my practice is, yes, in radicular pain, you can give it. That is what I would suggest. But yes, some of the commissioners might come back to quote on the NICE guideline and say like, okay, this is what it says. There's a bit of confusing thing, as well as it became a control drug. So I think there are lots of confusion with this. The problem is the NICE guideline says there is no evidence of benefit and there is evidence of harm. So tell that to the patient, and the patient understands and agrees, then you can give a trial and see. That is what I would advise. But NICE guideline is a bit controversial in that area. I totally agree with the person who made the point. I totally agree with that. It becomes a bit confusing. Yeah. But you can quote the NICE guidelines for neuropathic pain and prescribe if you want. I'm sorry to say that, but yeah, that's what I would do. Yeah.
Yeah, no, I think that's very true, and it is a really tricky area because obviously CG173 it calls itself a guideline for non-specialist settings.
Yeah.
And what they have said is that, as you say, if people are already taking gabapentinoids, manage on a case-by-case basis in non-specialist settings, not to initiate them. But as you say, Dr. Vasu, I think within specialist settings, consultants are still absolutely using that.
Yeah.
So it's
I think the problem came because many of the patients with back pain were prescribed gabapentinoids. I think when we start to use this, then we are using the resources in a wrong way, and that is what flagged the alarm bell. Today I saw an elderly lady, 84-year-old lady, who had significant back pain, and she was on buprenorphine patch at 70 microgram with gabapentin of 1800 plus tramadol. If I was taking it, I'll be collapsing on the floor. But patients do escalate it gradually and go up to the dose, and they get the tolerance. But if they have radicular pain, yes, there is a role for neuropathic, but make sure you've tried all the other things and use it as a combination therapy, and be careful and explain the risks to the patient. That's what I would advise. Yeah. Thank you.
Yeah, absolutely. Okay. Fantastic. Just on that point, before we move on, do you also find there's a lot of patients within clinic who have back and lower limb pain, but without any sort of specific radicular pattern? And I would suggest that maybe gabapentinoids have been overused in those patients in the past as well.
It's still overused, I would say. I would say still overused, because I think in clinical, of course, as I said, in secondary care, we see the tip of the iceberg. You are the one who are managing in primary care a huge number of patients. But the patients who come to the hospital, most of the time, rather than starting new medication, the pain clinic tries to optimize and reduce the medication. That is what we do. The reason is most of these medications become tolerant after some time, and they will still be taking it when they're not working. So it has been misused in the past for axial back pain, and it's still being misused, I feel. Yeah. Thank you, Graham.
Right, so I'm just going to skip forward to this question because I think it's sort of linked, actually. So another thing that the NICE guidelines suggest that shouldn't happen in non-specialist settings is combining medications. And of course, and this person has said, can you mix the drugs amitriptyline and gabapentin? And of course you can, and as you said in your presentation, you do. So what do you feel about that sort of area, combining neuropathic agents?
I think combination of medications have two things. One is they can give synergistic effect with benefit, and also with the problems they can make it more. So we need to keep an eye on that. There is no point in combining, like, say, 150 milligram of amitriptyline with 3,600 milligram of gabapentin. That's not a proper scientific approach. So if you're on a small dose of amitriptyline which is working and the patient is stabilized, and if you want to add gabapentin, I would recommend that, because there are studies to show that combination gives a synergistic effect. You can prove that. As I said, NICE guideline is a guidance, but on the other hand, I don't want them to be having two medications if both are, one of them is not working. So it's a balance of risk and benefit. And obviously, yes, amitriptyline and gabapentin, I would suggest you can combine, because both work by different mechanisms, but make sure that one of the drug is working, combining both of the drug. Don't add when one is not working. If it is working, then you can add another one together. But if amitriptyline is not helping at all, there is no point in carrying on amitriptyline with gabapentin. The recommendations come because of the polypharmacy. Many of the patients are taking multiple medications, and if you review them, they might not be helping, I think. So yes, I would recommend adding medications at a small dose, but just make sure you review and make sure that it is still helping, and document it in the clinical records, please.
Fantastic advice. So I'm going to just skip forward to a sort of related question that we kind of generated before.
Okay.
So yeah, I mean, I think as you obviously will be aware, quite often we've got only sort of 4 drugs, and those 4 drugs you can get through them quite quickly. You start talking about contraindications, people not tolerating a couple, and quite quickly you're through them. So I think you see sometimes coming out of hospital clinics the use of sort of off-label anticonvulsants, lamotrigine, topiramate, etc. I think, as you mentioned on one of your slides, specialist guidelines even include things like SSRIs. What's your thought about those kind of off-label type drugs, Dr. Vasu?
I think these are all have very limited evidence, and I would not be confident in recommending them to primary care. Okay. Even in my practice, I don't use them a lot. We use lots of other things like alternative medicines, complementary medicines, injection therapies to add. So that is what a specialist pain clinic does, rather than adding lamotrigine or other drugs, because these drugs have less evidence and they have more risk of harm. So when you're doing it in primary care, you have to be a bit careful when you prescribe this. And obviously, the reason why I said carbamazepine works in trigeminal neuralgia, but still I offer gabapentin or pregabalin. The reason is not because I'm bypassing the guideline, because we need to look at whether it is safe for prescription and follow-up. Most of my colleagues in the GP world here, I talk to them and they are happy with prescribing this drug rather than doing carbamazepine and monitoring for hyponatremia, for example. So each drug has their own effects and side effects. So patient safety is the priority. So I wouldn't go down apart from these 4 drugs in the primary care. If they have not responded, please refer to the secondary care and we will see what we can do. All the formularies in the country in the primary care always suggest only these 4 drugs. I've looked at the majority of them, not everything, but majority of them. And if it does not help and if the quality of life is poor, you have a right to refer this patient to the secondary care. And what secondary care can do is look at non-pharmacological approaches. We have lots of things like injections we offer. Don't promise the patient that they will do an injection. Send them to us for evaluation. And if this does not work, we look at other things, including complementary medication, complementary therapies, other stronger medications. Sometimes we give opioids, but I try not to give them. I'm against opioids personally, but you can give a trial. And more common is injection therapies that we do and other neuromodulatory therapies that we do, which has proper scientific evidence in the secondary care. Thank you, Graham.
Fantastic. There was a question around opioids, so that's answered 2 questions in one.
Yeah. There is a role for opioid. There is a role for opioid, but NICE guideline doesn't recommend it, number 1. And number 2 is when you start on opioid, go back to the British Pain Society website. The Faculty of Pain Medicine and British Pain Society have produced a nice document called Opioid Aware. And the worry of opioid is not just addiction. It is the risk. Maybe it's a separate topic. I'm going into that. But the risk is about other risks, including immunosuppression, bone density reduction, and other side effects. These are endocrine side effects. These are majority of the things which we don't find it. We miss it easily. So those things should be taken into consideration. So if a small dose of opioid helps, I have nothing against it. But most of these patients escalate the opioids and it becomes a big problem. As I said, people put a buprenorphine or a fentanyl patch and think it's an easy thing to do. But on the other hand, the dose of buprenorphine is significantly high, just very potent compared to other morphine equivalent. If you calculate the morphine equivalent, you'll be easily exceeding the morphine equivalent that the British Pain Society recommends in the opioid guideline. So be careful when you give opioid. A small dose for a short period, or if it improves the efficacy, that's fine. But in the long term, it will cause problem and you need to keep an eye on that. Thank you. Thank you, Graham.
Okay, so next question, we're changing tact a little bit now. And we're just going to ask about lidocaine plasters now. It's again quite topical. So this question is particularly with respect to post-herpetic neuralgia and your kind of experiences of how good they are.
Okay, they are good. Okay, they are good. As a pain consultant or a pain physician, we always say that we want lots of tools in our armamentarium because, as I said, the mechanism is different. And in my personal practice, I have found that lidocaine plaster works well in post-herpetic neuralgia. But will I recommend that? I have to be a bit careful when I speak in a national forum. The reason is most of the local formularies don't allow that. The reason is because of the cost versus benefit. And this is, again, a tool which was misused a lot by us clinicians, because we used to put lidocaine plaster for each and everyone coming with axial back pain, for example. That is not the indication. And we used it. And yes, it has some placebo response and patients find benefit in back pain, but it's not a radiculopathy or a neuropathic pain. Whereas in localized neuropathic pain, it does work very well. It has less side effects, easy to monitor, provided you use it for 12 hours on and leave the next 12 hours off. And all my patients have had benefit. But the problem I had is the formulary in my area in Leicestershire allows it only to be prescribed for post-herpetic neuralgia, nothing else. So if I work in the NHS, I can give it only for post-herpetic neuralgia, and the hospital will start it, and then the GP can take over, sort of thing. Whereas if I'm in private practice, I can prescribe. But on the other hand, this is a bit controversial, as I said. The NHS works on based on evidence, cost effectiveness, and efficacy. So it all depends upon your local formulary. Go and have a look at your primary care formulary and see what you can do. But in my practice, if you ask my experience, yes, it has a good evidence and it has got efficacy in post-herpetic neuralgia. More easy to prescribe. Yeah. Thank you.
Yeah, absolutely. It does very much depend on locally. I mean, in our area, we were successful in changing the formulary so that we could prescribe within the specialist service as an AMBER for localized neuropathic pain, more broadly than just post-herpetic neuralgia. Lovely. So the next question here, do pain management programs work? So I'm going to tailor that slightly towards neuropathic pain, because I think it is a really relevant question. Many of our patients will do a pain management program. But I think sometimes you get this just feel that, you feel a bit like neuropathic pain is different to other sorts of pain. It's more intractable. It's more, debilitating. And you sort of feel like people with neuropathic pain are going to be less represented or something in a PMP than back pain.
No, we do have. I think I would say in our pain management program, we do see quite around, I would say around roughly, I'm not having any evidence to back this up, roughly 1 in 5 will have neuropathic pain. Because it, as I said, neuropathic pain, nociceptive pain, nociplastic pain, all are mixed together sometimes. But we ask of majority neuropathic, what would you do? I would definitely consider a combined physical and psychological program, like a pain management program, if all the other treatments have failed, because there is a cost involved with the pain management program also. So the NICE guideline, especially for back pain, says if there are significant psychosocial obstacles, then refer for that. Evidence, yes, there is good evidence. There are papers to quote that we have very good evidence. The British Pain Society again has a guideline, a leaflet, the information leaflet regarding pain management program for clinicians, for patients also. But usually there are we do a stratification scores, especially if back pain, you have a start back pain tool. Similarly, we do a stratification tool and see whether we can try simple things like medications and other things. But there are some patients who come with significant yellow flags, what we say, which are like psychosocial factors which are an obstacle to the recovery. If you feel that there are a huge amount of things, then consider referring to the pain team, and they can look at referring to the pain management program. Whether it is effective, yes, it is a bit variable, because the patients we send to the pain management program are patients where all the other treatments have failed, and then we send to them, and it is in a group context. Not everybody can do a group program, in which case they can do individually tailored programs. They look into those things. But yes, there is a role for pain management program for neuropathic pain, but make sure you have tried all the simple things and refer to the pain clinic, and they will assess whether we can do. And when they go to the pain management program, they always have a triage system, and they check whether they will benefit from the program. But scientifically, yes, there is a definite evidence, but availability and restrictions are a big problem in the recent times.
Yeah, thank you. Yeah, really useful. I'm going to go backwards a bit, because we've got, since we talked about drugs and combinations of them and things, there's some more questions come up around that. So this question is, it says, how would you specifically know which drug is working if a patient is already on 2 to 3? I guess you already said you're going to add periodically, and you're only going to add if and if you meet the patient on several, it's just tricky, isn't it, I guess?
Yeah, I think we see this very commonly in our pain service. As I said, today I saw an elderly patient. I said she was on gabapentin, the pregabalin, butrans, tramadol, opioids. And then you think like this is not the right thing. So what I told her is she was coming asking for more medications. So I warned her saying like, these are the things definitely going to do harm. So first step is to educate them. Because without our education, they are coming looking for treatment and they think the medications are going to work. Then you need to explain to them that this is not the case. Your body has got tolerant. And maybe if you're on a huge dose, you might even be getting opioid-induced allodynia. So what we tend to do is educate them first. And then you look at the 4 drugs and look at weaning one at a time, slowly and gradually. Today's example in my clinic, this patient was on, there was another patient, I'll quote that, this patient was on 120 milligrams of Zomorph, plus a opioid patch, plus Oromorph in a small dose, plus the patient was taking pregabalin 600 milligram, plus the patient was on amitriptyline. So this was the problem I was facing. So then what I would do is in this patient, I would see which is the most harmful thing. In my perception, the most harmful thing is Zomorph because we have gone up to 120 milligram and along with the opioid plaster and the Oromorph. So my goal was to look at reducing the Zomorph by 10 milligram every 2 to 3 days. And we write a protocol. So do one thing at a time. Don't try to think like, okay, this is not working. We will try to stop everything. And the patient will lose confidence in you and lose the rapport. And the patient will go looking for a different GP or a different clinician. So what I do is I take one drug at a time, try to gradually reduce it, not stop it. And once the patient gets the confidence that starting from 120 milligram morphine, going down to 20 milligram twice daily has not made any change, then they will get confidence. And meanwhile, try to engage them. You need to get something like whatever facilities are available in the community. Maybe if you engage with a physiotherapist, if you have talking therapy, engage with them if possible. Say that I'm going to give you this thing. If there is facility for any other complementary therapies, include that. So give other treatments. At the same time, try to reduce it slowly and see to come down and achieve a goal. My goal in this case would be like going down to 20 milligram or 30 milligram twice daily. And once I reach that, then I would look at reducing the plaster after that and then pregabalin. So how do you know which one of the 4 drugs was working or not? Nobody will know unless you experiment it. The best person to tell is the patient himself or herself. So try to reduce slowly and gradually, and you will reach a point where you will find out which one is working or not. It is going to be a difficult task, time-consuming task, obviously, for people who are reviewing the drug. But unless you do one at a time, it won't. But you can educate the patient, write down a policy. That is what we are going to do. Obviously, patients who are drug abusers, patients who have significant psychosocial problems, it might not be straightforward. I'm giving a theoretical answer, but this patient was an elderly patient who was keen to reduce the drug. It was much easy for me. But some patients, it might not be. But on the other hand, you should tell that, okay, I'll give you a opioid rotation. I'll give you this. But the goal is I won't go above this and you need to reduce this. So make a contract which is agreeable on both sides, from our side as well as from the patient's side. So take one at a time. Take it slowly and gradually. These patients need to be taken care of because if you don't do that, these patients will come to the A&E or overdose and come to intensive care, and they are a huge burden to the healthcare fiscal status. So whatever we do, whatever time we spend with these patients, it matters a lot because we are saving the taxpayers' money. And this will help. Obviously, we will have difficulties. The patient will get angry with us, upset with us. Yes, we see that a lot. But on the other hand, we are doing an evidence-based approach. And it is better if we get the rapport of the patient and engage them in reducing this. We have had significant problems in some of the patients, in handful of patients. In those patients, we refer them to a combination. There are multidisciplinary clinics. For example, in Leicester, we have one of my consultant colleague who does a sort of medication de-addiction clinic. So they look at sitting with a drug abuse specialist and look at giving alternative things and weaning them. But it's only a small proportion, not a huge proportion. Majority of the patients will engage with us if we give a proper reasoning, and we will be able to reduce it. Sorry, I think I've given a long talk about that. Thank you, Graham. Yeah.
No, that's fantastic. And this person kind of related has asked about the combination of pregabalin and tramadol. So they particularly mentioned pregabalin 75 and tramadol 50. It's obviously sort of lowest dose, but yeah.
No, I think I wouldn't use any specific preparations like that because they are mostly costly compared to the individual drugs available on the formulary. My practice is to use pregabalin alone for neuropathic pain, and I tend to avoid opioids in these patients. But if I used a small dose and if it helps, yes, you try it. That's fine, perfectly fine. But I wouldn't go down the combination as a first-line treatment for me. It will be only in resistant patients. And tramadol is a rescue drug, and NICE guideline says use it for a short period in a small possible dose. So if you combine it, then it becomes a problem because you can't disentangle them, and you will be carrying it on for the rest of the life. And the commissioners will come back to you with the cost problems also. So my suggestion is try it separately and try to wean the tramadol after some time and carry on with the pregabalin. That is what I would suggest. Thank you, Graham.
Yeah. So, yes, a couple of these questions, which I think is quite useful. I don't know how easy it is for you to answer for us, but it's around the kind of, around some kind of neuromodulation and injections and interventions. And I think when you're working in the community, certainly for myself, kind of working in a community pain clinic, then for us, for example, we would actually have to, for some of this stuff, like things like 8% capsaicin, for any sort of injections, neuromodulation, we've got to refer out of area. And sometimes it can be quite difficult to know. Let's say you've got something common like phantom limb pain or diabetic neuropathy or post-herpetic neuralgia. Let's say you're already doing the prescribing, you've already got a team doing the sort of pain management program, and you're literally trying to decide whether there is an injection or an intervention or neuromodulation. Can you guide us at all on kind of what sort of patients would you want to see for that sort of intervention type side of things?
Okay, I think I would like all these patients with the neuropathic pain to have had tried these medications before they are referred, because my job in the secondary care is not to provide amitriptyline or gabapentin. This should be easily tried as per the formulary locally before they come. So obviously, if you have tried that, it gives us a challenge because you already tried that. I can't send back saying like, okay, try amitriptyline now. So then it means that we need to use the services available in specialist settings, and then we do that. Neuromodulation, I'll start there because that is easy to answer, because spinal cord stimulation, those sort of neuromodulatory procedures, we don't have it in Leicester. We have to refer to Nottingham Hospital, which is nearby. We are a tertiary service, but we don't do the neuromodulation. How many patients would I have referred? It's very rare, maybe 1 or 2 a year. You need to select the patient. We can't send everybody because they failed back to neuromodulation, because they have a referral criteria. They have a criteria for what they can do. So it is very difficult. And obviously, it does work. There is a role for each and every treatment. So I wouldn't refer everyone for spinal cord stimulation. That will be the decision of the secondary care. Who needs injections? Obviously, if you have tried all the medications, you're not succeeding, and the patient is getting some opioid problems, then refer them to the pain clinic, because we have got other things. Either we will consider injections, we will consider acupuncture or complementary therapies if it is appropriate, because again, there are restrictions in the secondary care, or we consider pain management program, or we might consider a combination of things. But if the patient's quality of life is affected, if you have tried your best with all the medications and the pain is severe and affecting quality of life, yes, you should refer to the patient to the secondary care. And the secondary care will decide what are the facilities available and do the needful. Obviously, we won't succeed in each and every patient, but it is worth trying something to improve the quality of life. It doesn't mean that injections work for everyone. That's not what I'm saying. But there is a role for everything. And obviously, sometimes the injection might be a way of easing the pain and giving them a confidence for a short period so that they engage in the pain management approach. So that might be the reason. So you try all the medications as per the formulary available in your local area. If this does not help, the pain is still severe, quality of life is affected, consider referring to the secondary care. That is what I would suggest, Graham. Hope that answers it.
Yeah, I think so. It's a complex area, isn't it? I think the people working in the community.
And just like medications, injections, pain management program, they also have failure rates. They also have restrictions. The evidence is variable in each and everything. But we see more sort of resistant patients where treatment didn't work. So it's better to send to secondary care, and we'll see what we can do. Obviously, rather than leaving it for a long time, it's better to send early, and we will try to do what we can within our limitations.
Fantastic. So I think we're... Okay, so there's another question here. So it says, my patients have told me that during the pain management course, they make patients sit around in a circle and talk about personal experience living with pain. patients don't get the opportunity to speak and it's not individualized.
Okay. I think,
yeah, I mean, I think that's tricky to,
Yeah, I think pain management programs have high level of scientific evidence, but I wouldn't say it's a panacea for everyone. It's not a cure for everyone. Yes, pain management program in the country, I'm sorry if I'm talking a bit more, but let me explain it. In the country, most of the country work on the British Pain Society guidelines, but the pattern and the way they organize locally differs from each and every area. Pain management program usually works on the principle of self-management strategies. So how can we make the patient manage their pain? In our pain management program, the doctor doesn't sit there. It is usually a physiotherapist, occupational therapist, a psychologist, a pain nurse, and sometimes a patient representative who sits and does the work. We want to try to demedicalize them and take them out of the medical model. That is the goal. And when we send, majority of the patients, they don't want to go after seeing them. Some of them will go there and say, like, yes, they're just chatting, I don't want it. Each patient is different. But what pain management program does is they look in multiple ways. They have psychologists who look in a cognitive behavior therapy. Some of them look at acceptance and commitment therapy, and some of them also have mindfulness-based approach. So they look at how patients can cope with the pain and keep active. The physiotherapist and the occupational therapist looks at how to pace the activities. So it looks like they're sitting and talking. The first day usually is an assessment day where they look at group dynamics. The program works well when the group dynamics works well. If there is one patient who can destabilize the group, then all of them won't progress well. So they have to select the patients appropriately and then work them. Pain management program is a small part of the whole pain services. It's not that everybody goes towards the pain management program. Some have injections. Even us, for example, we see around 15,000 patients in Leicestershire. We are quite a big service with 8 consultants. But how many patients go? Just few hundred, or maybe less than around 100 patients or so. So especially with the COVID time, we had been having problems. We closed for a long time sort of thing. So the wait time is also huge. But if a patient has a significant psychosocial obstacle to recovery, refer to them. Obviously, it doesn't mean that everybody will engage in the program, number one. Number two, not everyone finds benefit, but there are patients who find benefit. Even if a small amount of patients who go there find benefit, that saves a huge amount of money by reduction of medications, reduction of hospital stays, reduction of going to A&E, reduction of unwanted investigations like MRI scans. So that is what it does. But I totally agree with the person who made the comment. Not everybody likes it. Yesterday also had a patient who came back. You sent me to the pain management program, just chatting. I didn't like it. Yes, each person is different, and the expectations of the patient should be managed. So whenever they come, I ask 2 things. One is, what is your expectation from the clinic today, and what are your worries? So many of them clearly say, I don't want that. And that's perfectly fine. We don't send them to the program. There is no point in forcing them, because they are not going to attend the program, or they are going to go and just say, like, I don't want this. So if they don't want it, they send. So what we do is we tend to give the guide a leaflet about the pain management program and explain it. As well as BPS has a leaflet, patient leaflet with regards to the pain management. We give that and tell them, like, this is what it is. Read it and think about it and come back. If they want it, they go. Those who go there, and around 30 to 40% of the people will drop out after the initial assessment stage. The rest go on towards that. The portion who goes them, even they make a significant healthcare economical profit for us, because we, as I said earlier, we save all the costs related to this. But saying that PMP works for everyone is wrong. On the other hand, it's like somebody says, like, PMP is the best treatment, it works for all. No, it's not right. Each patient is individualized. Each patient treatment works differently. Can we give an individualized pain management program? It's not possible. The goal of the program is to work as a group. So we look at engaging them in a group. Why? Because it works better and it is easier, because we are using high level of resources for this program. You can't have one patient with so many clinicians sitting around. But if a patient can't engage in a group, for example, if a patient had significant phobia about group, then the team takes them individually and gives them, like, for example, in our service, we have something called coping with pain group. So this is like a pure psychology group, and they prepare them. And once they are prepared, they can engage with the main pain management group. So they know how to do that. But I get lots of rejections also, saying, like, okay, this patient is still waiting for investigation. I can't take them for the program. Yes, I agree. But it's worth trying if you have a doubt, saying, like, whether this patient will benefit or not. But if the patient is not willing, then there is no point in pushing. Thank you, Graham. I will stop there.
No, thank you so much. I think we've got through, I think, all the questions, or at least almost all the questions. So, I mean, thanks ever so much for asking so many questions and making it such a dynamic chat. And thanks to Dr. Vasu for answering all of them.
Thank you.
I think
I would like to take the opportunity to thank all the audience who have sat here so long after a busy day. Thank you very much, all of you. If you have any questions or comments, email Graham or Esther in the Pain Society, and I'm more than happy to, if they send me the questions, to answer back or direct you to the right literature if you need anything. Thank you very much. I'll stop there. Thank you, Graham.
Thank you. It's really, really generous of you, Dr. Vasu. So really, yeah, I'm just going to finish off by saying again, from behalf of the BPS, thanks ever so much for attending. Please do keep an eye on the webinars that are going to be coming up every month, and please do come along. The recording of this one will be on the YouTube channel. You'll receive the certificate with today's link and the evaluation form and the link to the recording in an email. And yes, that really just leaves me to thank Dr. Vasu again. Thank you to Esther to staying all the way to the end, which you did plan to do, and managing the slides. Thank you to everyone for attending. And once again, yeah, thanks ever so much, Dr. Vasu.
Thank you very much, all of you. Good night. Thank you.